to just say exactly what we heard for the surgical side, we need to apply to rehab as well. I've taken this as very much a physio-OT sort of program to address lymphedema. As we heard earlier, about 80% of the patients seen by surgery don't end up having surgery. It then falls to rehab. So, if I was starting it, I'd look at, first of all, what the patients tell us. Robin Ciela, who's here with me from Australia, did a survey of women in Australia. It was a national survey of women with lymphedema. These were the barriers that they had in access to physiotherapy and occupational therapy for treatment of lymphedema. The number one barrier was access to a therapist. We had the costs of treatment, travel, that this is all of Australia. Some women lived, 2 or 3 hour drive to see someone, not knowing where to get help, and then other things such as the time required for treatment and then sitting waiting for your treatment to occur. The other thing that her survey revealed is that women are not actually satisfied with what they're getting. They're looking for alternatives. She had some women looking, they tried 7 or 8 different sorts of treatments to try and find something conservatively that will help prevent it, to treat it, to manage it. So we have that information. We then, as I mentioned earlier, from the clinical, from observations of clinicians in our focus group, it seems that people are doing a mixed bag for the same patients. There is lack of consistency. Secondly, we know that there's lack of consistency in what garments they give and instructions, how they use it. When we look at measurement, Robin's going to present this tomorrow, it's a dog's breakfast. Everyone's using something different to be able to quantify lymphedema. Some people are using percentages, some are following the single limb, some are looking at absolute difference between limbs, and it's quite a long list. So, if I was starting a rehab service, commencing a service, I thought I'd look at priorities. First one, I would like to see evidence-based protocols based on severity of lymphedema and the underpinning of what is being presented. Mild cases of lymphedema that's predominantly swelling versus moderate or severe that have low fluid but high fat. Let's start differentiating out, because it's only that way we're going to be able to identify what is the right treatment for the right person. Secondly, patient-led goal settings. What is it that's important to the patient? And this was touched on by the surgeons this morning. We as therapists always know what's best. We like to tell the patient, we're going to do this or whatever, and that's going to help you do whatever. For other chronic diseases, and that's what it is, they've started using patient-led goal settings that include both the condition-related goals as well as lifestyle. We know that obesity is a big issue. If their goal was actually to lose weight and it had the spin-off of improving their lymphedema, it's a win-win. They've used this in back pain, in asthma, etc., and it's actually quite successful. You get better adherence, better compliance by using this sort of approach than having your patient come in and say, well, this is what you've got to do. You've got to do this self-massage, you've got to wear your garment, etc., etc., etc. Compliance drops off. The next one is, I'm from Sydney. We have 5 physio schools. Each physio school is looking for clinical placements. It's a problem that's everywhere internationally. It's the same for medicos. What I see is using students. We train the next generation at the same time for delivering, knowing how to assess, to identify the problem. They may not be skilled in treatment, but even if they recognize it, wherever they are, come across, they can then refer onwards. So we have lots of students. Our physio program has 250, just physio alone. We have exercise physiologists. I would like to be involved in this, and OTs as well. The next thing is standardized measurements and reporting. How can we evaluate what we're doing if we don't have standardized outcome measures? This does need to include patient-reported outcomes. As I said, I could just have pulled the first talk, put it up here. That we need to be able to look at different aspects, not just capture the volume, patient-reported outcomes, the presence of pitting, use ultrasound to look at dermal thickness, get a comprehensive view from clinical perspective for that patient. We need to do an annual review of our patients. We've heard the surgeons here saying, well, I've gone back and looked at over the year what we do. Are we doing the same thing? Are we seeing trends in our data? It's important that we can be able to reflect back. You need to have the standardized data to do that. And lastly, we need appropriate advertising. For us, in probably Sydney, most of the patients, they're 2-3 years out. They may no longer be being seen in the oncology unit. The GPs need to know where to refer onwards if we want the person to get access to treatment. That's one of the barriers I know in our region that we have. So that's what I would do if I was starting a program. Thank you.